Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Before I go into a discussion and demonstration of the slice technique, I would like to point out a few of the differences between the box preparation and the slice, and to also discuss the three types of slices: the full tapered, the modified, and the auxiliary. I'd like to now go to a diagram of a box preparation, just to show some of the differences. If you will note in the box preparation that on the buccal and on the lingual, we have come out into immunity by removing tooth tissue from the cavo surface margin to the pulpal axial line angle. This, of course, as you can see, necessitates the removal of dentin and enamel. In the slice preparation, you will note that we are into immunity with the edge of our slice on the buccal and on the lingual. Now, looking again at the proximal box, you will notice that it is not in immunity here before we start with the slice on either the buccal or the lingual. Therefore, we have removed only enamel to bring us into immunity. With this view of the full tapered slice, you will note that the slice itself comes from the cervical to the occlusal in one plane on both the buccal and the lingual. The slice is actually covered beyond the cervical floor, and then this is increased or enhanced with a bevel, as you can note here. The full tapered slice is seldom used anymore. It is not necessary with our elastic impression compounds to use a full tapered slice in order to take an impression. The modified slice looks just about the same as does a full tapered slice from the diagram and looking from the occlusal. However, if you will remember that this possibly is slightly less sliced than we had on the full tapered slice at the occlusal. In the modified slice, again, note the box. It is not brought into immunity on either the buccal or the lingual, but we are bringing it into immunity with the disking of the tooth, again, removing only enamel. From the proximal viewpoint of this, you will notice that the slices are of different lengths from cervical to occlusal. If you will note on the lingual, the corner of the cervical floor has been covered with a slice all the way to the occlusal. On the buccal side of this tooth, you will note that it comes maybe just 2/3 of the way to the cervical, but all the way to the occlusal. This indicates that these slices have been placed individually. We will show this again later as we demonstrate this technique. You will note then, too, that the cervical bevel connects up onto the slice, a millimeter, millimeter and a half, across the whole cervical, and then up onto the slice again onto the buccal, making it one continuous flow for this cervical finish line. Please note also in all of these slice preparations the beveling of the entrant angles. As we now go to the third type of slice, which is the auxiliary slice, you will note that we actually show here 4 areas of slicing: 2 on the buccal, 2 on the lingual. This auxiliary slice is utilized if the carious lesion has necessitated gross removal of tooth structure from under the cusps, and yet not enough tooth structure has to be removed to warrant a full protective cusp restoration. The unsupported enamel may be under either buccal or lingual cusps, or both. This illustration is being used to simply illustrate the change in direction of the slice from the modified or full tapered preparation. As I'm pointing out here, there's a change in direction going, in this case, to the distal on both the buccal and the lingual. In other words, the auxiliary slice wraps around the tooth to aid in future retention of the tooth structure itself. Of course, the auxiliary slice will also aid in retention of the inlay. As we look at this now from the proximal viewpoint, you will note that this is a modified slice preparation been placed upon this tooth, and then the auxiliary slices have been placed on both the buccal and the lingual. And then notice the full continuous line that we have, a free-flowing line connected by a bevel at the cervical into the modified slice, into the auxiliary slice. Note again, wherever the slices meet the cavus surface margin, there is an entrant angle bevel. The instrumentation for a slice preparation is carried out with lightning discs, mandrels, and the straight handpiece. Seldom do we use a contra-angle for slicing. The discs, as we can see here, come in different sizes. There is a 1/2 inch that we are not showing, and that is sometimes used, but 90% of the time a 5/8 inch disc is used for slicing the teeth. The 3/4 inch disc is used when the tooth is relatively long, and of course the 5/8 is too small to get into it. The 7/8 inch disc, which we see many people using, is not utilized in a modified slice preparation. We will now go to the mandrels. There are again 3 sizes of mandrels in the kits. The first is a 2-inch mandrel, the second 2.5 inch, and the third a 3 inch. It is suggested that you measure these mandrels so that you know which one you are using. The preferred mandrel is the 2.5 inch length. This allows us, as we will show later on, to get above the occlusal surfaces of the teeth without putting too much taper on the tooth itself. If we use a small, short mandrel, it is necessary then to use a large disc. And this is one of the things that we're trying to get away from in this modified slice preparation. Now I would like to go to a patient and show you the positions that we will use in slicing the different quadrants. The positioning of the patient is of extreme importance in placing the slice. First of all, if you're working in the upper right, as we'll demonstrate, we'll move the patient's head to the left so that there will be a good view for the operator. Then it is best to place a spheropter into the lower part of the mouth to protect the tongue from any involuntary actions. Finger position is such. The fingers of the hand that is not holding the handpiece should be placed so that they are protecting the lips of the patient. Then the handpiece is placed with a firm pressure. As you notice here, I have a firm pressure with my 4th finger on the patient's opposite lateral. And we now will come in and show a close-up of the disc in position against the tooth. Then, in this position, it is possible for the operator to tell the amount of taper, as you can see, as I'm bending my disc back and forth. You can see the amount of taper and thus reduce one of the tendencies of placing too much taper on the tooth. Now, if we can widen the shot, I can show you then how we will slice the lingual. That is taken care of the buccal for us. Now, bring the patient back slightly towards you, and then still in the same position, you come in and resting now probably back on the bicuspid, you will come in and directly look, and you can see that I have my disc now in the mouth. Position of the disc is such that I can determine the taper because I'm looking between the tooth and the disc. Now also notice why we are using the 2.5 inch mandrel. Without that mandrel, we would have to be putting a terrific taper to get beyond the head of this handpiece, as you can see where my thumb is. So that is the purpose of the long mandrel. Now if we're slicing on the lower right, we will just move the patient back slightly and tilt their head down a little bit so that the jaw is practically parallel with the floor when they are in the position for you to work. Pull the lip back with your finger. This is true if you're doing slicing or any type of preparation. Try not to pinch a patient's lip. And put a firm finger rest on the cuspid or the laterals on the opposite side of the arch. And then you will come down and you will see that I am looking between the tooth and the disc. If we could widen that shot just a little bit to show the hand position and my head. I am now looking, come back a little further, between the tooth. I'm looking between the tooth and the disc, as you can see now. So that is the position we'd be in. This is true for the bicuspids, for the molars. It can go way back to the second molar. You can still pull the mouth back and look in and see between the tooth and the disc. The lingual is very simple on the lower, and again it shows the importance of the long mandrel. The long mandrel to get over these teeth So we will now show, we would slice the lingual and we can slice the buccal. Notice my finger. That finger, if this should catch, and we hope it won't, and it doesn't very often, but if it does catch and it tunks into your finger, suddenly your foot will stop and you won't keep on drilling. This is one of the reasons that we like to use this instead of a mirror. Now we will go to the lower left. We'll slide our chair around, change the sphincter, and have the patient hold it on the left side to prevent the tongue from moving up into our field of action. Turn the patient's head slightly to the right now. And again, we're going to be looking, not this time necessarily from the buccal of the disc, but we're going to be looking over the disc in most of these instances to see just what angle we are slicing. Again, notice my hand, my fingers are holding the lip away from the preparation so that we can work in any of these positions and gaining our taper and the amount of tooth tissue that we wish to take. As we go to the buccal, we move our finger over like that and hold the lip away. We come to the lingual, the patient holds on, and we run the disc at a slow speed, very slow, and it will be a wiping action of this disc. We will demonstrate this a little more thoroughly on the typodont in a few moments. We will now go to the upper left position, which requires a complete change of the patient and the operator. We have to move the bracket table higher and raise the patient. This is one of the few times that we do have to stand. Now, the patient's head is just about in the correct position. And as you can see, we now will have, again, good access. This is one of the most important things in this procedure. Again, notice the fingers are protecting the lip and the cheek. And we now bring in the disc, and we can place it between the tooth that we are working upon. Notice the angulation. And I am, again, looking between the tooth and the disc so that I can determine the angulation that I wish or the taper that I'm going to place on the slice. Now the lingual is much the same, except we have to bend a little more, and we will look in here and place it and come a little more to the left, holding the position. Now I am again looking in, and I think a tight shot here might show that for us. But I'm looking between the tooth and the disc. So we then notice too that this mandrel is below the surfaces of the anterior teeth. Before I demonstrate the slice on the typodont, I would like to emphasize a couple of the points that we've been talking about throughout this demonstration. First of all, before a slice is accomplished, one must be sure that there is adequate taper in the cavity preparation. There must be adequate flare, and there must be freedom between the adjacent tooth and the tooth that is prepared so that the disc will not bind. One must also remember that you have to get access when you're looking into the tooth so that you can see between the tooth and the disc. It is extremely important to realize the way your instruments work. This is true whether it's in a slice or not. And in this case, with this instrument, one should realize that as we turn on the engine, there is a sudden surge, and we do not get a smooth start many times. This could be rather disastrous if it would catch in the mouth or outside the mouth. I will demonstrate this by turning on the unit. Did you notice the sudden jump of the motor? So be ready for this. One should be right onto it and holding very tightly with a firm finger pressure onto the engine and in the mouth. Now we will go into here and show the convenience form or the freedom of the disc that we need for placing this slice. As you can see, as I'm trying to go into the buccal with my disc, that it catches. Notice the catch. This is wrong. If we start now, all that we will do is catch the disc, and it will have a tendency to run into the gum tissue or into the finger that you would have here as a protector. Now also check the lingual, because we are going to be slicing individually. As you come into the lingual, you will notice that there is more freedom. There is more freedom here. It does not catch. So that means that we practically are out to where we have to be so that the disc will go through freely. From what we have just learned, it is now necessary for us to go back and re-examine the cavity. In doing this, we will change the position of the patient so that we can work with hand instruments if necessary. We'll first examine it with our Explorer. As you notice, the lingual wall was free for our disc, but it has very little flare. Now, we've talked the importance of flare, so we will have to enhance our flare. Coming to the buccal, you will notice that there is sufficient flare, but there is not freedom of our disc to get through without catching. So we will have to continue with the amount of flare that we have and yet bring it slightly more toward the buccal, not, however, completely into immunity, as we've said before. So we'll then take the appropriate hand instrument, and in this case, I would think that a Wiedelstadt or an enamel hatchet, whatever is the most handy for you, and we will work into this position, and we'll then start bringing this wall of the buccal to the extension that is required for our disc. After the use of the hand instruments, we should check the cavity preparation again. As you will notice now, there is extended flare on the lingual, and that's what we were after. The buccal still is flared the same as it was, and yet it is brought out further toward the buccal to give us that freedom that we require for our disc. After checking this, we will now position the patient so that we can slice. This means raising the patient up, turning the patient to the left, turning the patient to the left. And again, we will test our disc. We will test our disc. If you notice now, we can put our disc in from the buccal, and there's freedom of motion. It doesn't have much, but it's free. It will not catch. We will go back and check the lingual again, and there again we have the freedom. Now this means that we can place our slice, we can place the disc in there and run it without having the disc catch. I would like to just point out a little principle here on the conservative part of the slice preparation. This is one of the things that I've mentioned previously, that a slice preparation is very conservative for the tooth. I have on here a 669 fine diamond instrument, which many people use to bring their proximal walls out into immunity. Now, as we can see, we have taken the disc in and out of this situation without it binding at all. Now, I would like with a tight shot here, please, to show the diamond in the cavity preparation. If we were bringing this into immunity now, we would have to bring our diamond instrument out through this area, from the buccal or from the lingual. And as you can notice, it will not come out. The only thing that we can do here is to take off more tooth structure on the buccal or the lingual from the prepared cavity, or we will have a tendency to nick the other tooth, or to do both. So this is why we say that we have a conservative preparation with a slice. As we now get ready to actually put the slice on the tooth, it shows here that we will put the disc in, and notice that the disc is not revolving. I will now start the engine and revolve the disc slowly to the occlusal portion. Now, that is probably enough for the slice on the buccal. We will go to the lingual. We'll change our head position, not of the patient, but of yours, to see, so that you can see between the tooth and the disc, placing the disc again to the cervical extent that you wish, and then without moving the disc, then you start revolving the instrument and pull it to the occlusal. That is probably the full extent of the slice. After removal of the debris from the prepared cavity with a chip syringe, we will then reposition the patient so that we now can look into it a little better, and also we can finish up the bevels that are necessary for this preparation. If I could have a tight shot now, please. If you will notice, there are sharp line angles at the lingual and at the buccal where the slice meets the cavo surface margin of the occlusal. Now, as you look down into the cavity, you will notice that the slice does not go down through to the buccal nor to the cervical. You can see it in this shot. There's a little tiny bit of an indentation that you can notice here if you look very closely, especially on the buccal. The fine diamond or a small 242 burr will be used to put these bevels connecting the two slices and also to bevel the angles at the entrance of the prepared cavity. We will test our instrument to see that it runs, and then placing it into the cavity in a very straight position. And this is a sweeping motion, as you can see here. I'm going to draw this across, not put it into a tilting situation, or you will undercut the cervical points. Now, starting the engine, we will just sweep it across like that. That will probably place the bevel on the cervical. From there, we will go and place our bevel on the entrant angles. Starting with the lingual entrant angle, these angles now are beveled, including a part of the slice and around onto the occlusal, as you can notice here. The diamond is cutting about 1/2 to maybe even 2/3 the depth from the occlusal to the pulpal floor. Moving then from the lingual to the buccal, you will note that we now do the same thing, starting on the slice and carrying it into the occlusal. Very important. With the chip syringe, we will blow off the debris now and check the entrant angles and the cervical bevel. As we come in tightly now, you can see that these angles at the occlusal are beveled from about a millimeter or 2 on the buccal, coming around onto the occlusal. The lingual is the same way. This gives us an additional buccal gold that allows easier finishing. It gives us an additional amount of impression material that gives us a better impression, and it also aids in our waxing of the correct contours. You can see into the cervical that there is a bevel down across these two slices now, combining it all as one. For actually checking a slice and a bevel, it is important to really use a snap compound impression, which we will not do here today, but it is something that you should do as you do each of these preparations. I would like to show one more thing before we come to a conclusion, and that is the amount of taper that we have placed on this slice. I'll put the patient back again into a position that we can see from the occlusal, and we'll look again now from the buccal really, and I would like a tight shot here, I think, just to come in and show this. If we look here, you can see that from cervical to occlusal there is a slight taper, but very slight. Now this is important to us with our elastic impression materials. It saves tooth structure. It also aids greatly in retention. And it is not necessary to reduce this into a wide open taper on this slice. This is again accomplished by the use of the small disc.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.